Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers and specialists come together to learn about high-risk pregnancy conditions, share experiences and work together to ensure the best health outcomes for mothers and babies. Today we are learning about the identification, treatment and management of the high-risk pregnancy condition of heart disease in pregnancy. But first, let's meet our expert trainers.
Hello everyone, I am Dr. Karishma Tharyani, a senior obstetrician and gynecologist practicing in New Delhi. In today's session, we shall be talking about diagnosis and management of heart disease in pregnancy. Did you know that cardiac diseases complicate more than 2% of pregnancies in our country and are responsible for more than 1/5 of maternal mortality every year? It is very important to know about heart disease in pregnancy because quite a few of them may present for the first time in pregnancy itself. Of all the different types of heart diseases that may affect a pregnant woman, the most common in our country are rheumatic valvular heart diseases, which comprise of up to 80% of cases. On the other end of the spectrum are cardiomyopathies, which are relatively less common but represent extremely severe form of cardiovascular complication in pregnancy leading to maternal mortality. To tell us more about diagnosis, management, and different types of heart diseases in pregnancy, we have with us Dr. Poonam Tara. Dr. Poonam Tara is a senior specialist, maternal and fetal health at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Dr. Karishma.
Dr. Poonam, my first question to you is, why do heart diseases become more common in pregnancy, or why do they present for the first time in pregnancy?
So pregnancy has its own physiological changes, and these changes can have an effect on the cardiovascular system. That is the reason why the heart diseases can manifest for the first time in pregnancy.
What are those cardiovascular changes, ma'am? Can you highlight a few of them?
So there is an increase in the stroke volume. There is an increase in the total fluid in the body. This causes the heart rate to increase. The stroke volume to increase, and therefore the women in general feels more palpitations, can feel fatigued little more, and this, when there is a heart disease, can exacerbate, can get more and more.
So in a nutshell, the workload on the heart increases, which may lead to precipitation or unmasking of the heart disease in pregnancy. Dr. Poonam, what are the different signs and symptoms which an ANM should keep in mind, which may be indicative that the woman has an underlying heart disease, or in a known case of heart disease, which may suggest that her heart disease is deteriorating in pregnancy?
The ANM should inquire specifically about breathlessness, particularly when the patient is walking or when the patient is lying down, which is what is called as orthopnea. Increase in the palpitations in these women who are pregnant. There are other conditions where the patient may feel more fatigued, would have cough at night. These should all alarm the ANM that there may not be things which are right. She should also ask previous history of any problems in the past, which means in any previous pregnancies, or if she's had any joint pains during her childhood. Any family history of sudden cardiac arrest, which is a sudden death, or ischemic heart disease, can also lead us to, or lead her to understand that this is the lady who needs to go to the specialist to be able to review further. On examination, if she feels the veins coming out on the neck more prominent, or looking at the nails, what is called as the clubbing, these are the other few things which should alarm the ANMs to send these patients to the specialists.
So Dr. Poonam, if I were to summarize for the sake of our healthcare workers, will it be correct if I say that when a patient presents to the ANM or to the medical officer, it is best that they divide the patients into two different categories? First is a woman who is a known case of heart disease. In such a woman, the healthcare worker will ask her about any worsening of her cardiac symptoms like dyspnea, chest pain, easy fatigability, palpitations, or shortness of breath on lying down position. Check her vitals and see if there is any deterioration in her pulse rate or increase in her respiratory rate, or if the patient is suffering from fever or has increased jugular venous pressure. If any of these abnormal signs or symptoms are present, the patient has to be referred immediately to a higher center. On the other category are pregnant women who do not have any history of heart disease and who are presenting in any stage of pregnancy for the first time with cardiac symptoms. In such cases, the ANM will immediately refer such a patient to the medical officer for further diagnosis and management, and the medical officer will take a detailed history, do a complete examination, order investigations like chest x-ray, CBC, urine routine, and if the medical officer suspects that the pregnant woman is a case of heart disease, will immediately refer her to a tertiary level center. So Dr. Poonam, when you're telling a woman that she has heart disease, or a woman knows that she has heart disease, how should the family and the pregnant lady be counseled about the pregnancy and the course of pregnancy?
So the family members and the pregnant lady needs to understand that this is a high-risk condition where it can be life-threatening to the mother and the baby, and therefore an early referral to the tertiary center is important. It needs to be emphasized that rest is important, that good diet is important, and looking after the patient with respect to giving more diets rich in which can increase the hemoglobin and not having anemia. So all these things are very important for the family to know when she's being counseled.
So basically 3 main steps in counseling: adequate rest, anemia prevention, and infection control. Because any kind of infection or fever in a woman with heart disease and pregnancy can further increase the load on the heart, leading to worsening of the heart disease. Dr. Poonam, congestive heart failure or pulmonary edema is a common complication in women suffering with heart disease, more so in pregnancy. Can you please highlight the steps in managing this obstetric complication if it occurs?
As you rightly said, Karishma, that pulmonary edema is a complication, and it's a very dreaded complication of heart disease. It is very important to first recognize its pulmonary edema and then treat it accordingly at the earliest possible. Obviously, the symptoms are very important, and the symptoms does include coughing in night, lying down, having breathlessness, and then the signs which we talked about, the dilated jugular venous pressure. On auscultation of the chest, if there are creps in the lungs, that should also, warn the medical officers it is what they're looking as a pulmonary edema. They should ask for an immediate X-ray chest, and on the X-ray chest, the heart may appear to be enlarged. There could be hilar markings which are increased, especially in the upper part of the chest. There could be some fluffy interstitial markings as well, including the pleural effusion, and all these can confirm the findings of the auscultation that the doctor has done. Now, once the pulmonary edema is diagnosed, a referral becomes an urgent thing to the tertiary centers. The patient has to be propped up, given oxygen as 8 liters per minute. Effort should be made to reduce the venous return, and this can be done just by making the legs go down or by putting a tourniquet so that the venous return reduces and the cardiac load to the heart reduces. Furosemide can be given, which is Lasix, which can be given to the tune of 40 to 80 milligram under a proper monitoring, which includes the pulse, the respiratory rate. It also includes the pulse oximetry, by which oxygen sats are to be done closely and monitored regularly. So this should be done on a regular interval. Also, morphine helps, so morphine 5 milligrams stat IV, and can be repeated 3 times to the maximum about 15 milligrams. So this is all helpful things until the time that the patient goes to the tertiary level center. In case there is a need for it and there is a facility available, the oxygen sats are deteriorating, intubation has to be done. These are the few things which needs to be thought about and worked through for the pulmonary edema management.
Very true, Dr. Poonam. Pulmonary edema is a medical emergency. It is very important to identify it correctly and then remember that minutes count. So immediately the management and diagnosis should happen simultaneously.
Yes.
Dr. Poonam, when a woman with heart disease delivers the baby, is she completely out of danger now, or does she still require a postnatal care?
So the postnatal part of the pregnancy happens to be the most important part, because suddenly once the baby is delivered, there is increased venous return, and obviously the workload on the heart increases. So this is a time when these women with heart disease, after having delivered the baby, need to be monitored more with respect to developing pulmonary edema. So the monitoring, as we talked about earlier, in the form of pulse rate, respiratory rate, pulse oximetry, needs to be continuously monitored at least for the next 12 hours or so. Now, once we've decided, it's been decided that the patient is all set to go, a good counseling has to be done, where again the emphasis on rest, on increasing her hemoglobin needs to be done. It is also important that diet has to be emphasized on, and the family members are aware that there should be somebody who looks after the women once she goes to the back to home. So these are the few things which needs to be looked into after the patient is delivered.
Thank you, Dr. Poonam, for making such an important point. I think this is so important for us to remember, that even when a woman with heart disease delivers, she is not out of danger. She is at a higher risk in the postnatal period also, and she requires special postnatal care. So such a patient should be kept under monitoring once she has delivered the baby, because she is still at a higher risk of developing congestive heart failure. And even when she is discharged from the hospital, the family should be counselled about the 3 counselling points that we discussed in the beginning: rest, anemia prevention, and infection prevention. Only when these 3 points can be ensured should such a woman be discharged from the hospital.
And in case there is any anticoagulants that were going on prior, they have to be restored back, and a follow-up has to be arranged with the cardiologist post sending back the patient home.
True.
So along with the resting, it is important that pain relief is also given to the patient, because that increases the heart rate of the patient. So a good pain relief is important. Breastfeeding is usually contraindicated in women who have been diagnosed as having NYHA 3 and 4.
Dr. Poonam, we have seen that pregnancy with heart disease increases maternal morbidity, mortality. What are the different contraceptive options that can be offered to such women?
So the women and the husband needs to be told, at every cost, this has to be avoided. The pregnancy has to be avoided, because it is again a life-threatening condition, and contraception becomes of paramount importance. So contraception in the form of barrier contraception, which includes condoms, can be taken. However, they are not very efficacious. The important ones which are more efficacious are the ones where you can use a copper coil, or use the Mirena coil, which kind of gives the progesterone hormones and reduces the pregnancy rates. Also, along with the lactation, the mini pills, also called as Cerazate or progesterone only pills, is very helpful and can be done, because it does not affect the breastfeeding. So, and if the family is complete, then obviously the sterilization remains the gold standard. Any of these can be used and should be discussed with the patient before the patient is discharged.
So today, Dr. Poonam has busted an age-old myth for us that women with heart disease cannot be offered contraceptives as they may increase maternal morbidity. It is not true. Such women can be offered contraceptives like barrier contraception, IUCDs, or progesterone-only pills. If the patient feels that her family is completed and she is at low cardiac risk for anesthesia, then she may even undergo sterilization. Dr. Poonam, you have beautifully clarified all our doubts about this very complex topic and simplified it for our audience. Thank you so much for being here.
Thank you, Dr. Karishma.
So in today's session with Dr. Poonam, we have learned that heart disease in pregnancy is not uncommon and can cause increased chances of maternal and fetal morbidity and mortality. Proper diagnosis and management of such women require multidisciplinary team management at a tertiary level hospital. But for their timely referral, we need our healthcare workers to understand the simple signs and symptoms of heart disease and look for them in every pregnant woman so that no patient is missed and all the patients are referred on time to a specialist. To know more about the management of pregnancy with heart disease, please refer to our protocols. Thank you.
That brings us to the end of this training session about the identification, management, and treatment of heart disease in pregnancy. Remember to refer to the High Risk Pregnancy Management Protocol for more details.